Welcome back to Breastfeeding Nurtured, all you need to know. In our last session, we explained how to assess whether a baby is receiving enough milk, identified potential reasons for insufficient intake, and discussed practical strategies to improve milk production. Today, in session 8, breastfeeding, low birth weight, and ill babies, we will explore the importance of breast milk for low birth weight and sick babies, emphasizing continued breastfeeding, maternal support, and cup feeding techniques. The method of expressing breast milk manually and with a breast pump will be discussed in next session. So let's start with our first slide. This session focuses on the unique feeding needs of low birth weight and ill infants. After completing this session, participants will be able to explain why breast milk is the ideal nourishment for low birth weight infants, understand the significance of maintaining breastfeeding or providing breast milk for sick or jaundiced babies, support mothers in ensuring their low birth weight or ill babies receive breast milk effectively, guide mothers on the proper method of feeding their babies using a cup. The technique of cup feeding a newborn through pre-recorded video demonstration will also be shown. Let me first clarify the concept of low birth weight. A baby is considered to have low birth weight if their weight at birth is less than 2500 grams, regardless of how far along the pregnancy was at the time of delivery. Categorization of low birth weight babies include preterm babies born before 37 weeks of gestation who may not have reached their full growth potential, and small for gestational age babies born at full term, that is 37 weeks or later, but who are smaller than expected for their gestational age. Now, the global prevalence in many countries of low birth weight is significant, with 15 to 20% of all newborns falling under this category. Let us analyze why breast milk is ideal for low birth weight babies. Breast milk provides the ideal nutrition for all babies, most complete nutrition for infants, meeting their growth and developmental needs. Breast milk is especially important for low birth weight and sick babies as it offers essential nutrients and immune protection tailored to their needs. Low birth weight babies, whether preterm or full term, have a high vulnerability to infections and illness due to their weaker immune systems. Breast milk lowers the chances of severe infections, including sepsis, and reduces the risk of necrotizing enterocolitis, which is a serious intestinal condition. This leads to a decrease in mortality rates and supports better brain development. Breast milk plays a significant role in reducing neonatal mortality by boosting immunity and improving health outcomes. You might be surprised to note that low birth weight accounts for 60 to 80% of neonatal deaths. Breastfeeding plays a vital role in improving survival rates and overall health outcomes. Let us now discuss in detail the importance of breast milk, including mother's own milk and donor human milk in vulnerable newborns, including low birth weight and sick babies. Breast milk has immune boosting properties, significantly reducing the risk of late onset sepsis by about 19% in the first month of life compared to formula fed infants. Feeding low birth weight infants with human milk, whether maternal or donor, drastically lowers the chances of developing NEC, which is a severe gastrointestinal condition. The risk is as high as 79% when formula feeding is avoided. Donor human milk is easier for preterm babies to digest. Babies fed unfortified DHM show better tolerance to feeds, fewer instances of vomiting, reduced gastric stasis, and less diarrhea, leading to healthier digestion. Low birth weight babies fed donor human milk tend to experience fewer complications, leading to reduced duration of hospital stays. Shorter NICU stays also contribute to decreased emotional stress for families. DHM fed infants have lower rates of illness and hospital readmissions in their first year of life compared to those fed formula. DHM supports better neurodevelopment because of essential nutrients and bioactive factors that support brain growth and development. Preterm infants fed DHM exhibit greater brain volume, improved white matter development, and better cognitive and behavioral outcomes later in life. Feeding with DHM in neonatal intensive care units has been associated with reduced ROP, a condition that can lead to vision loss in preterm babies. While DHM may seem expensive initially, it proves to be cost saving in the long run. A study estimated that using DHM can save approximately $8,167 per infant by reducing the length of hospital stays and lowering the incidence of necrotizing enterocolitis and sepsis. Beyond infancy, babies fed human milk demonstrate a reduced risk of metabolic syndromes like obesity and diabetes in later life, as the early exposure to DHM sets the foundation for healthier growth and development. NICUs with a human milk bank report about 13% higher rates of exclusive breastfeeding at discharge, further emphasizing the value of providing human milk to vulnerable infants. Suffice to conclude that DHM provides both immediate and long-term advantages for low birth weight infants, enhancing their survival and quality of life. Let's analyze the differences between full-term and preterm breast milk as shown in the chart. The milk produced by mothers of preterm infants differs significantly from that produced by mothers of full-term babies. Preterm breast milk has a higher protein content than full-term milk, which is crucial for the growth and development of preterm infants. A significant portion of the extra protein in preterm milk consists of anti-infective factors, offering vital protection to preterm babies. The ideal food for low birth weight infants is their own mother's milk, as it is more easily digested and absorbed compared to formula milk. If the baby cannot suckle effectively, mothers should be encouraged to express milk for the baby. If a mother struggles to express enough milk initially, pasteurized donor breast milk can be given, if acceptable to the mother and in line with the country's policy, until the mother can produce enough milk. If neither maternal nor donor milk is available, preterm formula should be used as a last resort for babies weighing less than 1500 grams, while standard formula is suitable for those over 1500 grams. Breast milk provides all the nutrients necessary for low birth weight babies weighing 1500 grams or more. Babies under 1500 grams require additional supplements such as calcium, phosphorus, and vitamin D, while all low birth weight infants need iron starting at 6 weeks. Supporting mothers of low birth weight infants is crucial to ensure they can successfully provide breast milk. Babies who cannot suckle should be fed express breast milk through an intragastric tube or a cup. For this, the mothers require skilled support to learn the technique of milk expression. Post-delivery, mothers should begin expressing milk within 6 hours if possible. Regular expression every 3 hours is essential to stimulate milk production and maintain supply until the baby can breastfeed. Colostrum, the first milk, is yellowish in color and rich in nutrients and antibodies. It is especially beneficial for low birth weight babies as it protects against infections. Early expression ensures the baby receives colostrum even if only a few milliliters are produced initially. Collecting few drops of breast milk in a cup at this stage can be challenging. However, these can be collected directly from the nipple using a syringe. Baby can then be fed with the same syringe as shown in the picture. Let's first understand the detailed insights as to how low birth weight babies progress towards feeding readiness. It is also relevant for sick or clinically unstable infants who may exhibit similar feeding behaviors and require comparable methods. Babies less than 28 weeks gestation age weigh less than 1 1,000 grams make minimal mouthing movements and cannot manage oral feeds. They rely entirely on intravenous feeding. Oral feeds can be introduced when the baby shows tolerance. 28 to 31 weeks gestational age babies weighing approximately between 1000 to 1500 grams may begin opening their mouths, moving their tongues forward, and making licking movements. Suckling remains ineffective and they cannot coordinate suckling and breathing, necessitating intragastric feeding. 32 to 34 weeks gestational age babies weighing approximately between 1300 to 1800 grams start rooting, attempting to attach to the breast and may suckle weakly. While full breastfeeding is not yet possible, allowing the baby to try enhances their development. Cup feeding is introduced to support oral feeding practice, though intragastric feeding may still be required for some or all feeds. 33 to 35 weeks gestational age babies weighing approximately between 1600 to 2000 grams can root more actively and engage in organized suckling effectively, taking milk from the breast during brief periods. Breastfeeding can cover part of their intake, but cup feeding or other alternatives are needed to ensure adequate nutrition. Most babies with gestational age 34 to 36 weeks weighing approximately 1800 to 2000 grams can coordinate suckling well, though some feeds may still require cup feeding. Most babies beyond 36 weeks gestational age are ready for full breastfeeding and can meet their nutritional needs directly from the breast. Now we will discuss individual methods of feeding in low birth weight babies depending upon the developmental readiness and clinical condition. Let's have a look at the baby born at less than 32 weeks gestational age being fed via an intragastric tube. The optimal nutrition will be to feed the baby expressed milk from the baby's mother if possible because of its numerous health benefits. During tube feeding, the mother can also allow her baby to suck on her finger, which is believed to stimulate the baby's digestive tract and support weight gain by promoting gut motility and feeding readiness. The mother must wash her hands thoroughly before offering her finger for the baby to suck on. Now let's have a look at the babies between 32 and 34 weeks gestational age. You can see three different methods: feeding with a small cup, feeding with a spoon, and an image in the center of palate, which is preferred by some for newborn feeding, mainly in South Asia region. Cup feeding can be introduced once or twice a day alongside tube feeding. Gradually reduce tube feeds if the baby accepts cup feeding well. Some babies at this stage may breastfeed briefly, offer the breast before other method if possible. Cup and spoon feeding helps the baby learn to take food by mouth. It stimulates digestion and provides the enjoyment of taste, encouraging natural oral exploration if the baby cannot get breastfeed effectively. Feed cautiously with palate, as spout placement in the baby's mouth can lead to milk being poured directly. Encourage the baby to lap milk with their tongue as with cup feeding to maintain proper feeding technique. We will now discuss how to support breastfeeding in preterm babies between 33 to 35 weeks gestational age so that they receive optimal care and nutrition. Early breastfeeding can be initiated for a baby born between 33 to 35 weeks gestational age once they are stable. Initially, the baby may only root for the nipple, lick, or lightly suckle. Some babies may require supplementary nutrition through nasogastric tube. Mothers should continue providing express breast milk through cup or tube to ensure sufficient nutrition. Preterm or sick babies often pause during feeds, taking 4 to 5 sucks, followed by a rest lasting 4 to 5 minutes or longer. In such situations, encourage continued suckling allows the baby to remain on the breast and resume feeding when ready. Avoid removing the baby too quickly. Feeding may continue for up to an hour if their energy permits. However, it might not be possible for sick babies. Combination feeding can be practiced by offering a cup feed after breastfeeding to ensure adequate intake, or by alternating between breastfeeding and cup feeding. This slide focuses on breastfeeding for babies over 36 weeks gestational age, highlighting their ability to feed directly from the breast and specific care practices. Low birth weight babies over 36 weeks may feed more frequently than larger infants and often take long, slow feeds. Occasional supplements via cup feeding may still be necessary. These babies usually attach well with more areola visible above the baby's mouth, mouth wide open, lower lip turned out, and chin touching the breast, as you can see in the slide. Ensuring correct positioning and attachment helps facilitate effective breastfeeding sooner. Regular follow-up and weight monitoring are essential to ensure the baby is receiving adequate breast milk. Two recommended optimal feeding positions for mothers to hold low birth weight babies are across the body using the opposite arm to hold the baby, and underarm or football hold. In both positions, the mother supports the baby's body with her arm and controls the head with her hand. More head support is required for low birth weight and sick babies than full-term babies, but care must be taken to avoid applying pressure to the head. Now that we have discussed breastfeeding in low birth weight babies, let's focus on the vital role of skin to skin contact in supporting their growth, development, and breastfeeding success. This slide illustrates mothers providing skin to skin contact for the babies, a crucial practice for both preterm and stable sick infants. Skin to skin contact should be practiced for stable babies, with the ideal position being between the mother's breast inside her clothing, ensuring direct body contact. For babies too sick to be moved, the mother can maintain contact by gently placing her hand on the baby's body. Let's have a look at the key benefits of skin to skin contact. It supports breastfeeding by bringing the baby closer to the breast and aiding in the development of feeding skills. It enhances milk production by stimulating prolactin secretion, facilitates bonding by strengthening the emotional connection and boosting oxytocin release, and helps with thermal regulation by keeping the baby warm, using the mother's body heat, reducing energy expenditure, and promoting effective weight gain. It also improves physiological stability by regulating the baby's heart rate and breathing while reducing oxygen requirements, and encourages better behavior, resulting in less crying and improved sleep patterns. Mothers are recommended to provide skin to skin contact as often as possible for low birth weight or stable sick babies to enhance breastfeeding and overall well being, with feeding through a cup or tube being possible during contact. Building on the benefits of skin to skin contact, let's explore kangaroo mother care, a practice for nurturing low birth weight and preterm babies. Notice how the mothers are holding their babies in close contact on their chests. The babies are secured using a cloth or binder, ensuring they stay in direct skin to skin contact with their mothers. This practice is referred to as the kangaroo mother care, emphasizing prolonged skin to skin contact. Babies are kept in the position for extended periods, both during the day and at night. This setup allows mothers to move around and perform daily tasks while keeping their babies in close contact. KMC promotes successful breastfeeding and supports the baby's overall growth and development. We will now discuss common challenges in newborn feeding, such as jaundice and hypoglycemia. These can significantly impact the ability of low birth weight babies to feed effectively and thrive. Let us first discuss about jaundice. Jaundice is a yellow discoloration of the skin and eyes caused by high bilirubin levels in the blood. Early jaundice often occurs between the second and 10th days of life. Jaundice is more severe in babies who do not receive enough breast milk. Key measures to prevent and manage jaundice. Start breastfeeding early, preferably within the first hour of birth. Provide frequent and unrestricted breastfeeding. If using express breast milk, feed 20% more than the usual volume. Colostrum acts as a natural purgative, helping to clear meconium, the baby's first stool, and assist in excreting bilirubin, thereby reducing the risk of jaundice. However, a word of caution is to avoid giving extra fluids like glucose water, as they reduce breast milk intake and interfere with clearing jaundice. Let us now focus on hypoglycemia in low birth weight babies. Hypoglycemia or low blood sugar levels can be dangerous for newborns with low birth weight and sick infants being particularly vulnerable. Key recommendations to prevent and manage hypoglycemia include keeping the baby warm using methods like skin to skin contact, begin breastfeeding or give expressed colostrum within the first hour after birth. For babies unable to breastfeed, provide colostrum or expressed breast milk when available. If unavailable, offer other options like glucose water, formula, or intravenous fluids as needed. It is to be noted that healthy full-term babies are not at risk of hypoglycemia and do not require testing or supplemental feeds to prevent it. To summarize, timely breastfeeding and colostrum feeding are crucial for preventing jaundice and hypoglycemia in low birth weight babies. These measures promote better health outcomes and support the baby's growth and development. Let us explore the reasons why some babies stop breastfeeding when they are unwell. Understanding these challenges and addressing misinformation is crucial to ensure continued breastfeeding during illness. When babies are unwell, they may face challenges with breastfeeding for several reasons. Trouble suckling during respiratory infections can make it hard for babies to latch and suckle effectively due to nasal congestion or breathing difficulties. Reduced appetite during severe infections often lead to a loss of appetite, making the baby less interested in feeding. Inability to take oral feeds, including breastfeeding, after certain types of surgeries. Misinformation can also contribute to breastfeeding cessation during illness, like belief that breastfeeding caused the illness or mother is misinformed by some caregivers or family members that the baby's illness is a result of breastfeeding, leading to unnecessary interruptions. Advice from a health worker to stop breastfeeding either out of caution or misinformation, which can disrupt the baby's nutrition and recovery. Before helping an unwell baby to breastfeed, let us first understand what happens when the baby does not breastfeed or stops breastfeeding during illness and the benefits of continuing breastfeeding. When a baby stops breastfeeding due to illness, several negative outcomes may occur. The baby receives less essential nutrition. Lack of feeding can lead to greater weight loss. Without adequate breast milk, recovery from illness may take longer. The soothing and bonding effects of suckling are absent. The mother's breast milk production may reduce due to less frequent feeding. The baby might refuse to resume breastfeeding even after recovering. When a baby continues breastfeeding while unwell, they experience several advantages. The baby receives the most suitable nutrition for their needs. Regular feeding helps prevent excessive weight loss. Breastfeeding aids in quicker recovery, particularly from illnesses like diarrhea. The act of suckling provides comfort and reassurance to the baby. Continued breastfeeding ensures that the mother's milk supply remains adequate. The baby is more likely to maintain breastfeeding after recovery. Supporting breastfeeding during illness is vital for the baby's health and recovery. This slide outlines practical strategies to help mothers continue breastfeeding their unwell babies, whether the baby is in hospital or recovering at home. When the baby is hospitalized, mother's presence is very important. Admit the mother alongside the baby to facilitate breastfeeding and bonding, and allow the mother to spend as much time as possible with her baby unless medical complications arise. Encourage the mother to express her milk when not breastfeeding. Promote skin to skin contact or kangaroo mother care if the baby's condition is stable. This can stimulate milk flow and provide more opportunities for frequent breastfeeding. If the baby can suckle well, encourage the mother to breastfeed frequently, increasing sessions to 12 or more per day. During illnesses such as diarrhea, babies might prefer breastfeeding over other foods, which can help maintain to increase milk supply. If the baby suckles less than usual, suggest more frequent but shorter feeding sessions to ensure the baby gets enough nourishment. If the baby cannot suckle or refuses to feed, support the mother in expressing her milk and feeding it by alternative method depending upon the feeding maturity via spoon, cup or gastric tube if necessary. If the baby cannot take expressed milk from a cup, use a nasogastric tube for administering expressed breast milk temporarily until the baby can feed orally again. If the baby cannot take oral feeds, encourage the mother to express milk at regular intervals, including during the night, to maintain supply. Provide options to store the expressed milk or donate it to other babies in need. Let the baby attempt to suckle whenever they are willing, even if they are on intravenous fluids or supplemental feeding. Encourage the mother to resume breastfeeding frequently as the baby recovers, which will also build up her milk supply. Also support her efforts to reintroduce breastfeeding. However, re-lactation techniques will be covered in a later session for further support. Building on the support for mothers to breastfeed their unwell baby, cup feeding offers a practical and safe alternative when direct breastfeeding is not possible, ensuring that the baby continues to receive essential nourishment and care. It is particularly suitable for low birth weight or sick babies. Let's take a quick overview of the benefits of cup feeding. Cups are easy to clean with soap and water when boiling isn't possible, reducing bacterial growth and ensuring hygiene. A caregiver should hold and interact with the baby during feeding, thus fostering essential emotional contact and strengthening the bond between them. Cups do not hinder the baby's ability to breastfeed, though some full-term babies may prefer breastfeeding over cup feeding. Cup feeding lowers the chances of diarrhea, ear infections, and tooth decay compared to bottle feeding. Some of the alternative methods to cup feeding are palate feeding, which is a traditional South Asia method using a small pointed lip cup. While feeding with the palate, care must be taken not to pour milk too fast. Spoon feeding is another option of feeding newborns. However, it is less efficient, requiring more effort and time. Spoon feeding may be better for very ill babies who cannot manage a cup. Before diving into the step-by-step procedure for cup feeding, let's go over some practical tips to ensure a smooth and successful feeding experience. For mothers expressing small quantities of milk, encourage them to feed even minimal quantities to boost their confidence and milk supply. If excess milk is expressed, prioritize feeding the calorie-rich milk expressed later to promote the baby's growth. Therefore, cup feeding stands out as a safe, nurturing, and effective alternative, ensuring optimal care and nutrition when direct breastfeeding is not possible. We have seen that cup feeding is a gentle and effective method to nourish the baby when direct breastfeeding is not possible. This step-by-step guide ensures safe and comfortable feeding while maintaining the bond between mother and the baby. Begin by thorough hand washing to maintain hygiene. Prepare the baby by wrapping in a soft cloth to keep their hands close to their body and provide back support. Position the baby on the lap sitting upright or semi-upright. Place a cloth in front of the baby to protect their clothes from milk spills. Prepare the milk by pouring the estimated amount of milk for one feed into a small clean cup. Begin feeding by holding the cup gently against the baby's lips. Tilt the cup slightly so that the milk touches the lip. Rest the cup lightly on the baby's lower lip with the edges just brushing the outer part of the upper lip. Baby's readiness to feed is evident when they open their mouth and eyes become alert. A low birth weight baby may use their tongue to take the milk inside, whereas a full term or older baby may suck on the milk, possibly spilling some. Monitor the baby's response. Allow them to control the intake by sipping or lapping. When the baby has had enough, they will close their mouth and stop drinking. Assess milk intake. If the baby doesn't finish the calculated amount in one feed, they may consume more in subsequent feeds. Monitor the baby's 24-hour milk intake to ensure they are receiving adequate nourishment, as discussed in the next slide. Before we proceed further, let's watch a video demonstration on how to cup feed a newborn.
I will show you how a child sucks or takes the milk from a bowl or a katori, even if you do not have a spoon, which at times could be cumbersome. The moment the edge of the katori or the bowl touches the lower lip, the child protrudes the tongue and starts sucking the milk inside. After a few moments, you can burp the child and then restart feeding the child again. The child will leave the katori or will stop sucking once his stomach is full and he doesn't require the feed anymore.
Providing the right amount and type of milk is essential for the growth and well-being of babies unable to breastfeed. This guide outlines appropriate milk options and feeding volumes based on the baby's weight and needs. First choice of milk is always express breast milk, preferably mother's own milk or pasteurized donor human milk. Then comes formula milk, which is prepared in accordance with the manufacturer's instructions and WHO guidelines if the first choice is not available. Amount of milk to be given for babies weighing 2.5 kg or more is calculated with 150 ml per kg body weight. The total amount is to be given in 8 feeds every 24 hours, that is every 3 hours. For low birth weight babies less than 2.5 kg, the initial intake is calculated with 60 ml per kg body weight. The intake is increased by 20 ml per kg daily until reaching 180 to 200 ml per kg per day. The calculated amount is divided into 8 to 12 feeds, that is feeding every 2 to 3 hours. This is continued until the baby weighs 1800 gram or more and transitions to full breastfeeding. It's normal for feed amounts to vary across feeds. Baby may take more or less than calculated amounts when feeding by cup. Offer extra if possible, but let the baby decide when to stop. If a baby has small feed, offer extra at the next feed or provide the next feed earlier if signs of hunger are present. Regularly assess the baby's 24-hour milk intake. Supplement through intragastric tube only if necessary. Low birth weight babies require minimal milk in the early days, and even small amounts of colostrum can meet their needs. Tailoring milk type and volume to the baby's weight and condition ensures optimal nutrition and supports healthy development, even when breastfeeding isn't an option. While specialist care is ideal for low birth weight and unwell babies, there are critical considerations that caregivers should keep in mind when such care is not readily accessible. These guidelines provide practical advice to ensure optimal nutrition and care. Extra nutrients are required for very low birth weight and extremely low birth weight babies, that is less than 1 kg. They need extra nutrients like calcium, phosphorus, and vitamin D. Breast milk supplemented with nutrients offers superior protection against infections compared to artificial feeds, as it provides essential nutrients and protective factors unavailable in formula milk. Research shows breastfeeding is less stressful for low birth weight babies than bottle feeding. Babies do not need to learn bottle feeding before transitioning to breast. Direct breastfeeding is beneficial and avoids complications associated with bottle feeding. Donor breast milk is preferable to formula milk if the mother's milk is insufficient. Heat-treated donor milk can be used if HIV is a concern, though it loses some anti-infective properties. Even small amounts of mother's milk provide valuable anti-infective protection. Early feeding should be initiated within the first 2 hours after birth if possible, and feed every 2 to 3 hours to prevent hypoglycemia. Donor breast milk is the best alternative if the mother's milk isn't available. Glucose water or formula milk should be used only as a last resort. Feeding method by gestational age is the best indicator of feeding readiness, but weight can guide caregivers. Many babies begin breastfeeding at 1300 to 1500 grams and can fully breastfeed at 1600 to 1800 grams or less. Coordinated suckling skill, including suckling, swallowing, and breathing, develop by about 36 weeks of age. Before this age, babies may need pauses during breastfeeding or supplementary cup feeding to ensure adequate intake without overexertion. Building on the previous discussion, this slide highlights additional considerations for the care of low birth weight and unwell babies. These recommendations aim to support caregiver in providing the best possible care even in challenging circumstances to ensure the baby's health and well-being. Jaundice is common in newborns and usually resolves without intervention. However, certain types of jaundice may require special attention. Severe jaundice requires bilirubin testing to assess the need for further treatment modality. A simple indicator is the spread of jaundice on the baby's body. If it is visible below the umbilicus, referral for further testing is advised. Prolonged jaundice starts after the 7th day of life and lasts several weeks, may be harmless, often referred to as breast milk jaundice, or may indicate a more serious underlying condition. Steps for assessment include checking the baby's weight and feeding patterns, look for signs of infections, particularly urinary tract infections, and feel for liver enlargement. Management involves continuing breastfeeding if the baby is healthy, gaining weight, and has no liver enlargement, as breast milk jaundice is likely harmless. However, if the baby is unwell, showing poor weight gain, or an enlarged liver, they should be referred to a hospital for further evaluation while continuing breastfeeding. Hemolytic jaundice is caused by hemolysis of the baby's blood, often due to ABO incompatibility. It appears within the first day of life with bilirubin levels possibly exceeding 20 mg per deciliter. Management typically involves phototherapy with additional interventions as needed if bilirubin level rise under expert supervision. However, breastfeeding should continue with frequent feeds and maternal encouragement. Phototherapy is a common treatment for severe jaundice. Breast milk feeding should be continued during phototherapy by suckling or feeding expressed milk by cup or tube to maintain hydration and nutrition. Jaundice babies may be sleepy and suckle less. In such cases, the mother should express milk and offer additional feeds. Before switching to the key skills for expressing and storing breast milk, it is essential to address the unique considerations and practical techniques for supporting breastfeeding in babies with special needs such as twins, Down syndrome, or cleft lip, who often require additional time, effort, and support. This slide outlines practical approaches to support mothers and their special need babies in their breastfeeding journey. Key principles for supporting special need babies are: encourage the mother to start breastfeeding as soon as possible after birth. Ensure proper positioning and attachment to help the baby take a big mouthful of breast. If the baby cannot suckle effectively, teach the mother to express her milk. Use a cup or spoon to feed express breast milk until the baby can suckle well. Allow the baby to explore the breast and attempt attachment in their own way. Some babies adapt better than expected. Practical techniques for positioning include modified underarm position, which is suitable for babies who feed better upright, such as those with a cleft palate. The baby sits upright facing the mother with legs along her side and feet at her back. The mother supports the baby's back with her arm and their head with her hand. Alternatively, some babies with a cleft palate may feed effectively in a more reclined position. Straddle position is an upright feeding method where the baby faces the mother with legs on either side of her leg or abdomen, provides close contact and allows the baby to latch effectively while being well supported. That concludes session 8 on breastfeeding techniques for low birth weight and ill babies, where we emphasize the crucial role of express breast milk in ensuring that babies continue to receive its benefits even when direct breastfeeding is not possible. In the upcoming session 9 entitled Expressing and Storing Breast Milk, we will discuss the key skills required for expressing breast milk both manually and using a breast pump, along with proper storage techniques. We encourage you to share your thoughts, questions, or any topics you would like us to cover in future sessions. Feel free to reach out via email at rajinder_gulati@hotmail.com. Your feedback is invaluable as we strive to create informative, helpful content. Thank you for joining us, and we look forward to continuing this journey together. Have a wonderful day.